Okay, do you see the screen?
Yes, and everything is fine. Yeah, go ahead, please.
Okay, so greetings everyone, and I commend you for coming out for round two. I think round one was in late August. Anyhow, this is meant to be a dynamic, interactive session entitled Look What Came Through the Door, Case Histories and Infectious Diseases. So I've got about an hour of material, but we can do this as quickly or as slow and take our time and enjoy. So first of all, thank you for the invitation. I am sure I've spoken with all of you. For those of you who don't know me, I'm a specialist in infectious diseases. I treat everything except HIV, just because there are people far more capable of doing that than I am. Like all academic physicians, I spend my life looking for leading articles in the world's most prominent medical journals. And I live and work at the Health Sciences Center. The job for which I'm actually paid is infection prevention and control, but I do everything else as a hobby. I've been misquoted in the print medium. I've been abused by the audio media, and certainly tortured by ratemds.com. So, by this stage in your careers, you all know that the questions are guaranteed. It's that the answers aren't guaranteed, and sometimes there are no answers, or the answers are exceedingly difficult, or the answers take weeks to months to manifest. So this will be a practical case-based discussion looking at some common infectious disease problems seen in the office. It's not an encyclopedic dissertation. It can't possibly be. I'll try to be as practical as possible. Always verify the source and believe nothing you're told. And that was a joke. And I don't have any conflicts of interest. So I asked my son, what should I do for this session? He said, tell him some stories. So that's what I'm going to do. And I hope you realize that the history sometimes is critical to sorting out or unraveling the situation. Unfortunately, sometimes the history is non-existent, and we're left picking up the pieces from x-rays, blood tests, physical examinations, and sometimes even that doesn't help. So I want you to look carefully at this poster, because as, sorry, not poster, this sign on the side of the highway. We're all detectives in what we do. And you don't think you're a detective, but you are. So let's look at the sign and let's see if you guys are all detectives. Here we have the Richer Inn. Clearly they have a cold beer store. They have the La Gemaudier restaurant. They have rooms. And the most important thing here is they have the Cat's Ass Tavern. Now, I'm going to say to you, it's pretty bold to put a sign on the highway called Cat's Ass Tavern, and then have an arrow pointing at the cat's backside. So that's pretty crazy, but I was on my way to Kenora to give a talk many years ago, and I saw this sign, and I thought, I've got to go back and get the sign. So I went back and got the photo, and hopefully you've all enjoyed the ridiculous sign. Then the other thing is, it's amazing what you see on the street that you never realize. And here we have Helmut Sass, and it's on someone's lawn. I can't imagine how Remax allowed this sign to be on someone's lawn, but clearly they did. So, by attending this session, the attendee will be able to have an appreciation of common clinical entities in infectious diseases, recognize your role in thinking outside the box for our patients, and sometimes there's a great deal of thinking outside the box, and of course, have fun. And I'm going to say to you, work through some very interesting and some ridiculous cases. So for those of you who fall asleep, because it is getting 8 and it's getting close to my bedtime, in terms of having an appreciation for common clinical infectious disease entities, as you all know, working in the North, anything and everything is possible. And never stop thinking as anything can happen. Recognize your role in thinking outside the box for our patients. This is a no-brainer. Don't stop thinking. And if you're not sure, pick up the phone and call someone. And of course, have fun. We'll have some fun. So, what do you think? And what are we going to do? And this is dynamic and open mic. So please feel free to bark out answers. So the one word of caution is these cases will be presented to you in a couple of seconds. The reality is some of these cases took days to weeks to sort out. So, long-distance truck driver presents with a hot, swollen left wrist. And I hope you can appreciate that it's slightly erythematous. It's very tender. His medical history is remarkable for diabetes, hypertension, and he takes hydrochlorothiazide for his blood pressure, and his glycemic control is marginal at best. But here he is, big swollen wrist. What is your differential diagnosis? And what do we do with this? How do we investigate this? Or do we need to investigate this? And he has pain with any kind of motion, no fevers, no chills. And remember, you're in the north.
Look for a source for an infection, so like that could be causing cellulitis.
Sure. So absolutely nothing. No open breaks in the skin. The only striking thing on the skin is, the slight nicotine discoloration. But other than that, everything looks fine. So let's back up. What's your differential diagnosis? I mean, and if you want, I'll just talk and ramble, or we can leave it open mic and people can bark out differential diagnosis. Well, when I approach these, you've got infectious and non-infectious. For the non-infectious, you've got crystalline arthropathy, so gout and pseudo-gout. You've got acute rheumatologic disorder, acute presentation of rheumatoid arthritis or systemic lupus erythematosus, which is unusual because this is, a middle-aged truck driver. So lupus and RA, highly unlikely, but nonetheless in your differential diagnosis. Reactive arthritis, maybe had a gastrointestinal illness, and preceding this. And then we get into the infectious etiologies. The question that someone asked, or someone mentioned about, portal of entry for cellulitis. Sure. I would be worried about something inside the joint, and there's something inside the wrist joint, given the discomfort he's got with any type of movement. So common infectious etiologies are bloodborne pathogens. If he was an injection drug user, you'd worry about Staphylococcus aureus, either methicillin susceptible or resistant. If he was sexually active without barrier precautions, then maybe gonorrhea as a possibility. Could have a reactive arthritis from chlamydia. So what next?
Can we think of thrombophlebitis?
I mean, it could be thrombophlebitis, but he's got pain in the joint with movement. So I would say that's probably more likely something inside the joint, either an inflammatory process or an infectious process. He is diabetic, he's hypertensive, taking hydrochlorothiazide. That could predispose you to a gouty attack. So what's the next step? You need to make a diagnosis.
X-ray.
Okay, X-ray is completely unremarkable.
Lab work?
Lab work? His white blood cell count is 9, no neutrophils. He denies a fever or chills.
What about for gout?
The uric acid is marginally elevated. So the next thing, no matter how brutal this is, and I won't admit that I am an
Yes.
expert, you have to aspirate the joint.
Yes.
And the reason for aspirating the joint is to obtain fluid for crystals
Mhm.
and fluid for ideally cell count, but the wrist is a teeny weeny joint, or let me correct that. The wrist is a joint made up of teeny weeny joints. So you want to collect fluid for crystal analysis, you want to collect fluid for cell count, and you want to collect fluid for culture and gram stain. Ultimately, what was found is that he had monosodium urate crystals in the wrist, and he was treated with a non-steroidal anti-inflammatory agent. And that makes sense because he denied any sort of unprotected sexual encounters while in his travels. He was overweight, diabetic, and with on hydrochlorothiazide. So a hot, swollen joint could be gout. And that's ultimately what this man had. You know, gout usually appears in the first metatarsal phalangeal joint of the foot, but as you know, in clinical medicine, anything is possible. So many years ago, immediately following the SARS outbreak, I was driving past Sears Polo Park, and I saw this sign, and I thought to myself, this is amazing. Sears is commemorating SARS by turning off their E. Okay. This fellow had a cardiac, a 4-vessel cardiac bypass surgery. And about a month after the surgery, he developed a small draining area in the midline of the incision. And on further questioning, he reports that the incision never really completely healed in that area. So now the question to you, what is this? And what do you do with it?
So probably this is obviously this is looks like deep sternal wound infection, and probably this is some either suture material left on and probably making a sinus, and I don't see pus material come in, but
So you're dead on. I mean, anytime you've got an incision and a drainage in the midpoint of the incision, whatever's underneath is causing the problem. So
Exactly.
we were able to use a sterile probe right down to the sternum. You could do a CT scan for confirmation, but what the CT scan will show you is disruption of the sternum and changes that could be post-surgical plus or minus infectious. We did a CT scan that showed us exactly that, some inflammatory changes. There was seropurulent material that yielded methicillin-susceptible Staphylococcus aureus.
Okay.
Treatment is intravenous antibiotic.
6 weeks.
So we treated him with 6 weeks of intravenous ceftriaxone. The sinus closed. He did fine. So if there's an incision that doesn't close completely, or that opens up even a small area after a surgery, and if there's implanted hardware such as prosthetic knee, prosthetic hip, shoulder, elbow, etc., you always worry about a deep-seated infection that's device-related. Here, it was likely from the sternotomy, and this is a common occurrence.
Yeah,
So
thank you.
so I have a patient similar story, but she was healed completely. Do I need to do X-ray for the sternum?
Okay, but okay, if it healed completely,
Yeah,
then there's no problem. I mean,
yeah.
if it heals and then opens up and drains, you have a problem
Okay,
because it
okay.
could be related to the sternal wires. There could be an osteomyelitis. Remember, you're cutting through the sternum, and who knows what the vascularity is in this person.
Mm-hmm.
So I gave a talk in England a number of years ago, and I saw this sign, an elderly people crossing. Truly shocking. Okay. 47-year-old man who thinks he was bitten by a tick 12 years ago. Now, you know you're in trouble when this story begins, when someone thinks they were bitten by a tick. The best stories are someone finding the tick stuck to their leg or on their chest or on their back, or their spouse found it somewhere. He has a 10-year history of fatigue, vague, non-specific complaints, foggy head, poor thought, poor concentration, muscle and joint pains all over the body, subjective muscle weakness. He believes that he had a tick bite about 12 years ago. His family physician gave him 3 weeks of doxycycline just in case. He's seen 3 different neurologists and a specialist in physical medicine. He's had 2 MRIs of the brain and spine and no diagnosis. Serology at Chatham Provincial Laboratory has been negative twice, 4 years apart. He consults a naturopath who sends the blood to the United States, and the patient now brings you a 14-page result that states he has Lyme disease, and he demands treatment with intravenous ceftriaxone for 6 months. What do you do?
I consult the tick clinic.
That I agree. Get this out of your office as fast as possible.
I
This is
refer
not
to
gonna
you.
end well. So I'm going to give you a few hints. If someone thinks they were bitten by a tick 12 years ago, I mean, the best cases of Lyme disease are the ones where the patient's wife, brother, sister, child, whatever, takes a picture and you've got the beautiful bullseye rash. No rash and the belief that you were bitten by a tick, and then these non-specific symptoms that have gone on for 10 years. 3 neurologists and a specialist in physical medicine, and there's still no diagnosis? Unlikely to be true Lyme disease. So we come down to the next line that says, serology for Lyme from Chatham Lab has been negative twice, 4 years apart. The serology done at Chatham Lab is the same serology done at the Mayo Clinic and the Cleveland Clinic. So based upon conventional testing and by history, this man really doesn't have anything that suggests Lyme disease. I caution you that there are for-profit laboratories. There's one in Palo Alto, known as IGeneX, and the naturopaths will charge, I think it's $1,200 for the test. It's sent by courier to IGeneX, and the results are invariably positive. There's one in Germany called Armin Lab that specializes in arthropod-borne illnesses, and those results are invariably positive as well. Demands treatment with intravenous ceftriaxone for 6 months. What is this lunacy? For Lyme disease, and look, early on, the family physician gave 3 weeks of doxycycline. So this just-in-case treatment would have treated Lyme if it had been Lyme. So now what? I agree with the comment about refer to the tick clinic, because this is going to be an incomprehensible story. So when we look at the Infectious Diseases Society of America guidelines for Lyme disease, human granulocytic anaplasmosis, and babesiosis, they say there is no convincing biologic evidence for the existence of symptomatic chronic Borrelia burgdorferi, or Lyme, infection among patients after receipt of recommended treatment regimens for Lyme disease. Antibiotic therapy has not proven to be useful and is not recommended for patients with chronic, more than 6 months, subjective symptoms after recommended treatment regimens for Lyme disease. So really, I don't know what to make of the patient's symptoms. There's no serologic evidence of Lyme disease using conventional laboratory techniques. And he did receive just-in-case treatment. So honestly, I'm not sure what to do with these. My first nasty comment on ratemds.com was where I basically told someone that based upon our conventional stream of medicine, they didn't have anything that would suggest Lyme disease, and they didn't warrant a prolonged course of treatment. And that got me a nasty comment on ratemds.com. So the IGeneX laboratory, and this is from their website, states on their lab results, there's a disclaimer at the bottom that says the diagnosis cannot be made exclusively on the basis of laboratory results. You need to have the history of the bullseye rash to help consolidate the history and confirm the diagnosis. And here is one of the results. These things are incomprehensible. I remember reaching out to Jared Bullard at Chatham Lab to try and get him to explain this to me, and he had no idea. So down here they say, diagnosis should not be based on laboratory tests alone. Results should be interpreted in conjunction with clinical symptoms and patient history. The problem, however, sometimes the patients come with a very strong history and very strong demands. So I'm not sure how to address this. I just want to make you aware that this is out there and to be cautious. And if in doubt, a referral to the tick clinic, and it's run by the WHA, and you can find the referral form on the internet. Any questions? Any comments?
I unfortunately have a client who is being treated for a tick for Lyme disease. He's gotten the tests done in Germany. Canadian tests were negative. Germany were positive. He's been going through a naturopath. He does go to the tick clinic, but the naturopath prescribes all this weird stuff. And if Dr. Goulet will agree to it, then we will do it.
Yeah, no, I agree. I think,
But he spent thousands and thousands and thousands of dollars.
I agree,
Admittedly, he is ill, but
but
I think
probably
it's
not
much
with
more.
Lyme disease.
I
So
don't.
all I can say to you is this likely isn't going to end well for you. It's not for you in particular, but for us as physicians, it won't end well. It will end up with a complaint at the college that you're withholding therapy, or a nasty comment on ratemds.com, or a violation of trust and therapeutic relationship. So I don't know what to do with this. It's a brutal situation. And when I get the referrals, I too send them straight to the tick clinic because I can't help these people. And I've got far sicker people with life-threatening disease that need my help.
The
So
only
if
problem is the tick clinic only operates half a day a week or something like that.
Yeah.
That's my understanding.
So that, like, when they will see the patient?
When you're in Mexico and someone says to you mañana
Mhm.
means tomorrow, but when someone says to you mañana, that means don't hold your breath. They'll see the patient eventually.
I know, but like the treatment will be delayed.
But I think what Kathy Schofield Singh was saying is that her patient had innumerable tests, but only the ones done out of country were positive. And I've seen a load of people just like this, where the tests done at Chatham Lab, and if there's any question, Chatham sends those tests for confirmation to the National Microbiology Laboratory. And I think what Kathy's patient was looking for was validation of whatever illness there is with some organic process. Maybe this person has anxiety, depression, OCD, etc., but that's not a true medical diagnosis. I don't know. Like, these are exceedingly difficult cases to treat. Do any of you have oh my God, delusional parasitosis patients in your practice? Equally difficult to treat. because the person has to believe in your diagnosis and embark upon a treatment program with yourself. And that patient population is exceedingly difficult. Okay, let's move on to the next one. 47-year-old man, otherwise well, presents 3 weeks after having been at the cottage over a weekend. Wife noticed an expanding bullseye rash. And here it is. You've got the real thing. It's basically almost like when you drop a pebble in a pond and you get the rings. So here you've got it. And basically, these are organisms, and you've got the massive inflammatory response. And this one's easy. This fellow's got Lyme disease, he's got the classic rash. The problem with classic rash is that the rash can look like anything under the sun. So if you find a tick if you find a tick and this unusual rash, it's Lyme disease until proven otherwise. Initiate treatment, draw the serology, and do serology 6 weeks later for confirmation. But the key is amoxicillin or doxycycline. But what I say to people is that if there's any question that there could be a cellulitis, give amoxiclav, because that will kill staph and strep, as well as Borrelia burgdorferi.
How
For
long do you keep them on for?
10 to 14 days.
10 to 14 days.
And here's Borrelia burgdorferi. It's a spirochete, and it's transmitted by ticks. And here's the eruption. It can look like anything under the sun. It's a great mimic. So the characteristic eruption is sort of this target lesion or bullseye, or even like the rippling pond. But if you look at this child with the spots, so when in doubt, treat, draw serology, and do follow-up serology later on. I'm not originally from Manitoba, and I can say to you, I agree with the owner of this pickup truck. I too hate snow. Okay. A spry octogenarian couple. Soroush joined this couple on holiday. He was sitting at the same table with them when he was taking time from being in the north. That was a joke, by the way. A spry octogenarian couple observed that on embarking on a cruise, they saw staff in hazmat suits, and they were cleaning one of the suites on the floor where their cabin was. They asked the cruise staff, "What's going on?" And the staff on the boat said, it's standard practice on all cruises. Intermittently, dinner mates develop vomiting and diarrhea and disappear from the dinner table. What's going on?
Gastrointestinal illness, food poisoning.
Exactly. This is norovirus. And norovirus will whip through, or I shouldn't say whip, will rip through cruise ships. And the CDC has a whole document on travel and preventing travel-related illness, and norovirus is one of them. If you think about it, on these cruises, I've never been, so I can only speculate from what I've seen. You've got salad bars, you've got close quarters, you're mixing people from around the world, and you're also mixing their germs. So good attention to hand hygiene, and those people in the hazmat suits were actually sanitizing the cabins. There must have been someone with norovirus in that cabin. So the moral of the story is wash your hands. Okay. 34-year-old otherwise well woman, originally from Ghana, traveled to visit relatives in Ghana. She spent a month living with her relatives and doing and engaging in all of the activities that she always engaged in. Upon returning from her trip, she develops an irritating cough that went on for 5 months. She coughs up this large white worm that she brings to you for your appointment, in a grocery bag. Now what? Who is this character? And how do you put the whole story together?
Check the chat there. They've got some options.
Oh, check the chat. Okay, sorry, I am barely computer literate. Check the chat. Okay, check the chat. Okay, I'm checking the chat. Sorry. I've got a problem with my chat. Ascaris, exactly. So, that's Ascaris lumbricoides, and it's a big worm. It looks like a piece of spaghetti. And basically what happened to this lady, she did everything with the relatives. She got Ascaris lumbricoides, and part of the life cycle involves bursting through the alveoli and traveling up the trachea. And her irritating cough was likely the parasite irritating the trachea. Okay, I've done something with my computer. Hold on. There we go. So it's a common organism, fecal-oral transmission, and treatment is mebendazole, albendazole, ivermectin. So, if this person lives with someone else, you would want to check the feces for ovum parasite of the roommates or, people with whom they live, and treat everybody at the same time. This person certainly warrants treatment. And the clinical manifestations include vague abdominal discomfort. You can get a Loeffler syndrome, which is due to parasite parasites in the lung causing an allergic reaction. So we have the smoking gun, which is the parasite that the lady coughed up. Okay. 30-year-old man spends a week not at a 5-star, at a 6-star all-inclusive resort in the Dominican Republic. Does echo treks into the wooded, marshy areas. He was overwhelmingly bitten and mercilessly bitten by swarms of mosquitoes, despite wearing mosquito repellent. Within 1 week of returning to Canada, he develops rash and mild headache. And here's the rash. So the question to the group is, what is this? What's the most likely pathogen that could cause this, and what do we do? Well,
Is it
Dominican
dengue?
Republic is an endemic area for dengue. And the history of a rash, mild headache, viral symptoms, all fit with dengue. So you could do dengue serology. You could also do serology for chikungunya. But really, there isn't much to do other than reassurance and wait for the serology.
Sorry, Dr. Embil, I have a
Yes.
question regarding dengue fever. What's your experience regarding dengue-related intracranial hemorrhage? Like, there were a few case reports that I read, and I came across a very interesting patient. Like, he had intracranial hemorrhage despite having platelets of the platelets were within normal limits, but he still had this hemorrhagic.
Well, I regret to inform you that my experience is non-existent. And honestly, our experience locally with dengue has been that it's a relatively benign condition. Clearly re-exposure in the future can lead to more aggressive symptoms, but I don't have any experience with such severe cases. As you know, clinical medicine is evil, and if it can happen, it will happen, and it will invariably happen to you when you're on call. So unfortunately, I don't have any. I don't have any meaningful comments other than, you know, keeping track of geographic location of travel and common epidemiology is critical for making the diagnosis. And I can't comment about you know, more grave situations. Sorry.
Yeah, possibly it was like a second episode for this guy.
Certainly possible.
Yeah, thank you.
Okay. A family goes to a popular American theme park. They stay at a high-end resort at the theme park. The kids pet a beagle that patrols the corridors with a handler. And the parents aren't really sure, but they think that maybe the dog is sniffing for drugs or bombs, but they don't tell the kids anything. 2 days into the stay, many members of the family develop an itchy eruption. What's going on? How do we put all of this together?
Look like flea bite.
Please,
Sorry?
Flea bite.
please.
Fleas. You know, that's a brilliant thought. But the dog is in impeccable condition. You would hope it's not fleas. What else would you worry about?
Bed bugs?
The kids find this cute bug and they say, can
Yeah,
we
bed
keep him?
bugs.
Bed bugs. So the dog wasn't sniffing for bombs or drugs. It was a bed bug sniffing dog. And the dog can smell blood because they've got an infinite number of scent receptors compared to humans. So the dog is actually sniffing for blood, and blood presumably from the bed bugs. So
Obviously, he missed it.
clearly the dog missed clearly the dog missed those bed bugs. An art-loving couple go to Paris for a week to conquer the Louvre. The female member of the party awakens at 2 a.m. and cannot fall back asleep. So she turns on the light in the bathroom to use the toilet. A critter skitters across the wall. Now what?
Hit it with a slipper.
Hit it with a slipper. Sure. So thankfully, although it is a terrifying creature to see, and you don't want it in your room, it's not going to cause you any illness. So regrettably, I suspect that that hotel in Paris has lots of cockroaches, and there's not much we can do about it. A 40-year-old carpenter from Winnipeg travels to Baker Lake for hunting. They shoot a variety of local creatures, and they sample them all. Several weeks later, our carpenter from Winnipeg develops nausea, vomiting, abdominal cramps, pyrexia, myalgia, and occasional bloody stool.
Was he eating raw meat?
They did it all.
Excellent.
I would say it's
Hey.
some kind of parasite.
Okay, so let's look at his blood tests. White count is marginally elevated. His hemoglobin is normal. His CK is 31,000.
Like trichinosis or something? Or
Okay, this is the physical examination. This is the only thing on physical examination, with the exception of diffuse myalgias. He's got this subconjunctival hemorrhage. So the thought of trichinosis is dead on, because one of the things they shot was a walrus. And one of the things they ate was raw walrus meat. So we're quite fortunate that we were able, and this case took weeks to sort out. We were able to find out the person. So we were basically able to backtrack, get a chunk of the meat, and have our pathology department do histopathology on the meat, and we have confirmation of Trichinella spiralis in the meat, and there it is. So treatment with antiparasitic agent, that only kills the parasites in the gastrointestinal tract. It doesn't kill the parasites that are encysted in the muscle. And the subconjunctival hemorrhage was basically a parasite that was in the subconjunctival area. So this man had trichinosis, and don't laugh, this is the story of the walrus and the carpenter. A healthy and adventurous 45-year-old Winnipegger visits Tijuana, Mexico to experience Mexico. He samples the local delicacies from street vendors, and within 24 hours, he experiences abdominal cramps and 5 liquid bowel motions. What's happening?
Traveler's diarrhea.
That's it. This poor fellow's got traveler's diarrhea, and it should resolve in a couple of days. Pepto-Bismol may be of benefit. If it goes on longer, a brief course of ciprofloxacin may be of benefit. So the moral of the story is avoid street vendors. I'm really not sure about the sanitary conditions here, but it looks deep fried, so maybe it's okay. Okay. A healthy and cautious 16-year-old girl visits Mexico on spring break. She stays and eats at a high-end resort. She doesn't leave the compound. Within 24 hours of arriving in Winnipeg, she develops abdominal cramps and bloody diarrhea. Now what?
What was she eating? Like chicken, poultry, fish?
Whatever they had at the resort that was prepared in their commercial kitchen.
Well, she's got some dysentery of some sort. So
Okay, so what's the next step?
find out what's causing it.
Stool
Okay.
samples.
Okay, so stool specimens are submitted for culture, and ova and parasites, and nothing. The stool doesn't have any enteric pathogens. There's no E. coli, Shigella, Salmonella, and there are no parasites.
It's toxin-induced.
Okay, so we observe for a few weeks, we repeat the specimens, and still nothing. And she's still having intermittent abdominal cramps, some bloody diarrhea, and some mucus per rectum.
Maybe another diagnosis, like not infectious.
I agree. So she ends up having a colonoscopy. She had Crohn's disease. So this was her first manifestation of Crohn's disease. So the history confounded the situation. A 27-year-old adventurous man samples all of the local delicacies of a local tropical vacation destination. And I trust you can appreciate the subtlety in my comment about all of the local delicacies. Within a few days, he develops what he thinks is a urinary infection. He pushes fluids, but the symptoms don't resolve.
STI.
He has an STI. So he presents to you, he shows you his penis, and he says, "What is this drip I've got? What do you do with this fellow?"
Looks gonococcal.
Okay, so what do you do?
Swab it,
Okay.
Treat it.
treat it,
Okay.
treat
How
everything
did
else
you-
that could be it as well.
Sorry?
Treat everything else that goes with it.
Absolutely. So you're going to treat gonorrhea, chlamydia, and the thing is, we don't know if we're going to see this man again, and we'll do serology for hepatitis B, C, and HIV, as well as syphilis. So, okay,
Yeah.
very good.
But you also have to report it now, but because he was overseas, I don't know. Like
Okay,
we reported
so-
to our system.
Okay, so here's the thing. Thankfully, so I would strongly advise you to collect a specimen for urine, a specimen of urine that will go to the lab for nucleic acid testing. they'll confirm the presence of gonorrhea, chlamydia, and then public health will contact him directly because there's direct public health to laboratory reporting. So the second they find a gonorrhea, public health will be all over him to try and sort out where he got it, what's going on, and they'll provide him with advice on appropriate behaviors. So agree. A fellow goes fishing in the north. He's impaled by the fins of a pickerel, and 2 days later he's got an infection. He's treated with cloxacillin, but it gets worse despite the cloxacillin. There's maybe an initial improvement, but it gets worse. And I don't know if you can appreciate, but this digit is quite swollen, and that's despite having had cloxacillin. So now what?
MRSA.
Well,
Good point. You know, it could be MRSA. I mean, this person could be colonized.
Or
Could
the
be
cloxacillin
Aeromonas,
wasn't
'cause-
appropriate.
Or the cloxacillin wasn't agreed.
Yeah.
One of the
Could
things we
be-
need to remember is that with fresh water exposure, there is Aeromonas hydrophila, which is a gram negative. And, you know, cloxacillin should kill staph and strep. In all likelihood, from the puncture from the fins of the pickerel, either the lake water or bacteria on the pickerel led to an inoculation, and we did indeed recover Aeromonas hydrophila. So that's treated with piperacillin, tazobactam, meropenem, ertapenem, maybe even some success with ceftriaxone. So bottom line, always think outside the box, and it could be more than just run-of-the-mill staph and strep with freshwater exposure. To celebrate the end of exams, 6 students go to Banff camping. One of the more adventurous students decides to drink water from a stream. Within a few days, the student develops profound flatulence, abdominal cramping, and diarrhea. Stools are greasy and float.
It's all Giardia. That's all there is around there.
Exactly. And the treatment is metronidazole, and metronidazole. And you're right. So he has beaver fever, and it's from the beavers defecating upstream. And the reason for the greasy stool is basically from a massive malabsorption syndrome from the trophozoites sticking to the lining of the small bowel, preventing absorption. Years ago, I saw a fellow who'd lost a pile of weight. He looked sick. It was thought he had a small bowel lymphoma. He had Giardia. And he'd had Giardia for probably 6 to 8 months, which is why he'd lost all the weight and he looked sickly. It was insane. Oh, for those of you who were here back in July, August, we've talked about this case before, but for those of you who weren't, diabetic man presents to the emergency department with his foul-smelling foot. What do you do with this person?
Call you.
Okay.
We have to control the source.
Okay, so
Yeah.
you call from the north. My answer is give them whatever you've got. If you've got ceftriaxone and Clinda, give that. Send them, and we'll see them in either an emergency or clinic. And this person needs, I agree, control the source of infection. You know, there's a huge necrotic patch. He needs an extensive debridement. Bottom line is the foot was essentially non-salvageable at the time the man presented. He had an extensive debridement. This is what was left after all of the necrotic tissue was resected. He was left with a non-functional foot. He declined amputation. He went on for a couple of years and then had the amputation. So he would have probably been better off having the amputation early so that he could do physical rehabilitation so he wasn't so debilitated. In any case, serious diabetic foot infection, polymicrobial, aerobes, anaerobes, gram-positives, gram-negatives, broad-spectrum treatment, and then focused therapy once you've got the microbiology back. Okay. Non-healing wound on the sole of the foot in a non-diabetic person. It was not painful, and the home care nursing staff had applied every lotion and potion known to man.
Squamous cell.
Okay, you know, I'm going to say to you, and I don't know if the rest of you see this, but it's certainly a most unusual appearing lesion. It's heaped up. Most neuropathic ulcers are flat. They erode deeply. This is an exuberant lesion. So whatever this is needs to be biopsied. And it ended up being a melanoma. And basically an acrolentiginous melanoma, because it was found on the sole of the foot. Thankfully, lymph node dissection did not demonstrate any metastatic spread. So this person got away with a big debridement and retention of their foot. I saw this guy with his girlfriend in Osborne Village probably 20 years ago. And I couldn't believe that someone would be so bold as to have this, you know, show this sign. So I had to give him some money because I felt so sorry for the guy. This fellow presents with profound, painful peripheral neuropathy, develops a local infection, has a debridement, and then 4 weeks later presents with this exuberant lesion on the sole of the foot. What on earth is this?
Is it excessive granulation tissue?
Well, that's what it looks like. And I can tell you
Yeah.
it was a pretty unusual situation. So it was treated with silver nitrate, and it kept getting more and more exuberant. A biopsy confirmed a squamous cell carcinoma. I know, like, clinical medicine is insane. Okay. This fellow has a coronary artery bypass surgery. He develops heart block afterwards and gets a pacemaker. The problem with the pacemaker is about a month later, he has an erosion here and an erosion here, and we can see the device. What next?
Is he reacting to the device?
I think what happened is that the device wasn't implanted deep enough, and the skin basically necrosed over the device.
You would need a plastic surgeon to cover it.
So your suggestion is brilliant. The problem, however, is now that the device has been exposed to the environment, we can only presume that it's infected. What this man needs is removal of the device and reimplantation on the other side. So this is a bit of a bother, but thankfully there's no overt evidence of infection. But if we are to excise the superficial soft tissues and put a skin covering, it's probably 50-50 in terms of survival. So the preferred approach, removal of the device, reimplantation of new device. I was in Edinburgh years ago and I saw this. I guess people in Edinburgh spit a lot of gum onto the ground. Okay. 44-year-old female, you know, awful peripheral vascular disease. She has a coronary artery bypass surgery in 1999. She had an aortobifemoral bypass graft. And then in 2003, she has a revision in 2003, and now presents with this. What is that?
The graft.
Now what do we do?
Call vascular surgery. And start her on IV antibiotics.
Absolutely. Now, whether you give antibiotic or not is neither here nor there, but this is not something that stays in the nursing station. You don't push the graft back in. This lady needs urgent intervention. You can see this dreadful purulent stuff. Take a deep specimen. You know, if she's not febrile, you can wait until she gets to Winnipeg to start the antibiotics. Or, you know, if there's any anxiety on anyone's part, start the antibiotics, but take the specimen for culture first. So this is not treated with antibiotics. This is not treated by pushing the graft down and putting a dressing on top. This requires a surgical resection and new bypass graft. Most likely organism, probably Staph aureus. Early on, Staph aureus is the most likely pathogen. Later, organisms like Enterococcus, Staphylococcus epidermidis that are less virulent are the most likely pathogens. And early infections are within 6 weeks. Late infections are anytime after 6 weeks. And the same thing holds true for implanted orthopedic appliances. Within the first 6 weeks, early infection, Staph aureus, either methicillin susceptible or resistant, and more than 6 weeks old is late infection, and the less virulent organisms, such as the coagulase negative staph, Corynebacteria, Enterococcus, are the more likely pathogens. Okay. 62-year-old retired laboratory technologist cuts her leg while gardening. 4 days later, there was purulence at the site. 6 days later, she's got shaking, chills, and nausea. Attends at the local emergency department. She's diagnosed with the flu and discharged to take chicken soup. Within 24 hours, she feels normal again, but receives a call from the emergency department saying that the blood cultures yielded Staphylococcus aureus. Now what?
She's feeling fine now. Wouldn't you just monitor her and see if she's doing okay?
Okay.
Echo.
So, sorry?
Echo.
Okay. So now this story takes a crazy twist. And I'm going to give you the whole story, and then we'll discuss what we do. So
For
what
me,
was
I
done?
would refer her to the emergency department.
Okay. So
Mm.
then let me ask you, what would you do when you return her to the emergency department?
Like treat her.
Okay.
Yeah.
So what was done for this lady? You feel fine? Perfect. Staph aureus was probably a skin contaminant. She now presents 6 weeks later to the same emergency department with sweats and terrible back pain.
Yeah,
What
she's got
happened?
She's got
Osteomyelitis.
Exactly. So what happened to this lady is she had a bacteremia from the laceration on the leg. Staph aureus is not routinely considered a skin contaminant. It is considered a true pathogen. And the reason we aggressively treat Staph aureus with effective anti-staphylococcal therapy, either cloxacillin, cefazolin, vancomycin, daptomycin, is to make sure that if there are any metastatic spread, those metastatic foci are eradicated. So what happened in this scenario, she received the phone call. She says, feel great now. The problem, however, is organisms had already seeded the spine. She presents 6 weeks later with relapse of the infection in her back. She has back pain, and the MRI shows spondylodiscitis. So what should have happened is that when the blood culture was positive, she should have been recalled. She should have had the echocardiogram. She should have had repeat blood cultures, and she should have had initiation of antibiotic treatment with effective anti-staphylococcal antibiotic therapy to basically address the occult foci. So this is a case of a missed opportunity for treatment. Have you guys encountered Staph aureus bacteremias?
Yes.
Yeah, it's not to be messed with. If you
No.
find a Staph aureus in a blood culture,
Yeah.
bring the patient back, go over them from head to toe, because there could be something more sinister going on. It's not a contaminant.
So would you do oral antibiotics or
No,
IV antibiotics?
No, you want to make sure first of all, cloxacillin is a nasty drug. It gives everyone diarrhea and dyspepsia. And it's nasty given IV as well. It causes a lot of irritation of the vein. You would treat IV to ensure that you get high therapeutic levels. Clox, Clox is used, lots of Clox is used, but its oral bioavailability isn't great, and its tissue and bone penetration is okay. So you want to treat this aggressively with IV. And whoever said echo, I agree. You want to do echo to make sure that this person hasn't ended up with an endocarditis. So when you look at the plain radiograph, pretty underwhelming. This is the finding on CT. You've got some erosions, and then MRI shows a far more dire picture. So bottom line, Staph aureus bacteremia, if you're not sure, call infectious diseases on call. If you want, call me, I'm always around. But Staph aureus bacteremia is serious and requires a review of the patient to make sure that you're not missing more sinister underlying cause. Okay, the youngster, 18-month-old child, goes to a petting zoo, does whatever 18-month-old children do, which is kiss pigs, eat feces, etc., develops diarrhea and flatulence after visiting the petting zoo. Now what? Collect a specimen. Stool for ovum parasite.
Exactly.
Sorry?
I was trying to unmute myself just to say that.
So stool for ovum parasite yields Dientamoeba fragilis and Blastocystis ominis. Who knows if these two organisms are actually true pathogens causing a problem in this scenario? Regardless, the child was seen kissing a pig, so it's possible that the child got one or both of these and they're causing gastrointestinal discomfort. Treat with metronidazole, see if the child improves. I'll pass you. This is a recycled case from our last session. Oh my God, in the summer. Long-standing type 2 diabetes presents with a hot, swollen right leg and foot in comparison to the contralateral side. It's not particularly red. What's your differential diagnosis? And what do we do?
Could also be a DVT if he's a traveling salesman.
Sure, could be a DVT. I mean, planes, trains, and automobiles, of course. So ultrasound that was done doesn't reveal anything. It just shows some edema in the soft tissue and nothing else.
Well, there's definitely some skin breakdown there. So is
Right.
it a cellulitis due to an infection through
But
an
I'll
open
tell
area?
and I apologize, this is an old digital image from the early days of digital cameras, but really the foot looked just like this. It wasn't particularly red. It was hot though. The right foot was hot.
It looks
and
more,
swollen.
the right foot looks more red than the left foot though. And
Okay,
it's definitely swollen.
And
but it didn't
the little
look
toe's
cellulitic,
red.
though. Sorry?
The little toe looks a lot redder than everything else too.
Sure. But I'm
Um,
gonna reassure you that to my eye at the time that I saw this person, it did not look cellulitic. like this, the whole thing didn't make sense. In retrospect, it all made sense. So when you look, it's certainly it's thicker. And I tried to get them at roughly the same size and shape, but this one's probably I was probably closer. The foot looks thicker. It's got a ruddy complexion. And the plain radiograph shows that he's sheared off this metatarsal head, this metatarsal head. He's got a fracture here. He's got a fracture here. So this man has fractures of the bones of his foot and not an actual infection. So he has a Charcot-arthropathy in evolution. We treated him with casting and not antibiotics. Okay. This fellow works for Hydro. He spends most of his time working in remote locations, and he comes to the city once or twice a month for banking and basically social activities, movies, dinners, dates, whatever.
Do you have syphilis?
Well, he presents with this spotty rash on his hands. And we ask him, do you have spots anywhere else? He's got spots on his feet. What are you going to ask this man? If you ask him, do you have syphilis? He's going to say, huh?
Do you have any sores on your penis?
Well, funny you should say that, because he did. About, I don't know, 4 weeks before, 5 weeks before the spots, he did have a painless boo-boo on his penis. And he thought he'd gotten his penis caught in his zipper, but he didn't remember ever having any pain. And what other questions would you ask this man? Who are you having sex with, and are you wearing a condom? His response is, yeah, sometimes we wear a condom. But he doesn't know who he's had sex with, people he's met in bars. So we have a problem here. The easy thing to treat is syphilis. We can give him a shot of benzathine penicillin G. Okay, so this lesion, we're looking at the well-circumscribed ulcer on the shaft of the penis with the rubbery edges is primary syphilis, the syphilitic chancre. The lesions on the skin are secondary syphilis. So treatment of primary and secondary and early latent syphilis is benzathine penicillin G, 1.2 million units administered into each buttock. Latent syphilis is 1.2 million units once weekly on 3 consecutive weeks. And neurosyphilis confirmed with lumbar puncture is treated with basically 2 weeks of either intravenous penicillin or intravenous ceftriaxone. Someone had a question.
Shall I treat him for 2 weeks or 3 weeks?
This man?
Just for the benefit of doubt, yeah.
No. So this man has secondary syphilis. Treatment is 1.2 million units intramuscular into each buttock, so 2.4 million units. So you don't need to do anything. Treponema
so one dose.
1.2 million units intramuscular into each buttock, so 2.4 million units total for primary and secondary syphilis.
Because like at HSC, they told us, because for benefit of doubt, at least give 2 doses, like 2 times injections.
Well, if there's ever any question about what you're doing, go to the internet and type in Canadian STI guidelines, syphilis, treatment.
Yeah.
And then and if you want to know the follow-up, you do the exact same thing. Canadian STI guidelines, syphilis, follow-up.
Manitoba has their guidelines too.
Yes.
What about the resistant syphilis that's coming out now? There's been reports of that.
I was unaware of, there's resistant gonorrhea.
I thought there was some resistant syphilis.
I was unaware. So
And
I won't make a comment because I was unaware.
Yeah, I may be
And
wrong, but I thought I heard that.
There's
Is this-
resistant gonorrhea. Yes, madam.
is this is the dollar sign on the lesions in the hand? We
I
call
don't
it
know. I mean,
dollar
this is
sign.
classic
Yeah.
palms and soles.
Yeah.
So if anybody presents to your office with lesions on the palms of the hands, it's either hand, foot, and mouth disease or syphilis, and I would not shake their hand. In fact, I would
Mhm.
avoid them like the plague because those lesions
Mhm.
are full of treponines.
Okay. They say that it's crossing the palmar lines, creases, and it's
Okay.
called dollar sign. So I don't.
Okay, thank you.
Yeah. Yeah. Thank
Now,
you.
it's 9:21. I can keep going or I can stop and we can do a follow-up, some other time. You tell me, what do you want to do?
Please go ahead. We have time.
All right, go ahead. You have time. Okay. Oh, in the old days, when I was a medical student, we had the capacity to do dark field microscopy, and you would milk the serous fluid from the base of the ulcer. You'd take a drop of the material, you'd put it on a slide, you'd use the dark field microscope, and you could see the spirochete seen here under dark field microscopy. That's gone. Now it's clinical finding and serology. The moral of the story is wrap that rascal. Now, you're also going to collect a urine for gonorrhea and chlamydia. You're going to do serology for hepatitis B, C, and HIV. And hopefully our patient doesn't have any other pathogens. And he's going to get counseling on appropriate barrier precautions. Okay. An employee of a local telephone company is sent to service equipment in a remote location. He opens the door of a small building where the equipment is located and notices a number of mice running by. There are mouse droppings and dried mouse urine and puddles of mouse urine on the floor and on all the equipment, and there's dust everywhere. After exiting the building, the worker noticed that he's slightly short of breath and he's covered in dust. Because of increasing dyspnea, he presents to the emergency department expressing concern that he might have hantavirus. His co-worker brings in one of the mice, and it's a little mouse with white feet and a white tail. So, what's the likelihood of this man having hantavirus? Zero.
Zero, because he doesn't. It's usually the deer mice that cause the hantavirus.
Well, even more significant, he was literally just exposed. You've got a 5 to 7 to 14-day incubation period. This man has a reaction to the dust, or maybe he's got anxiety, but he certainly does not have hantavirus. So I think we can strike that one off the list. And I think we may have had a case of hantavirus in Manitoba about 20 years ago, maybe. And there it is, the white-footed mouse. Okay. A young woman goes to a local beauty salon and has her ear pierced up here. Within about a week, she calls the beauty salon and says, "My ear is really sore. What should I do?" Beauty salon says, "Well, I'll clean around the stud with an alcohol swab." She calls back a week later saying, "It's really swollen and really painful." They say to her, "Take out the stud." A third week goes by, and she presents to the Health Science Center Emergency Department. What's going on?
It's perichondritis.
Exactly. And I'm sure the pain that this lady was experiencing was excruciating. The ear tissues are stretched tight. She went to the operating theater for an incision and drainage. The concern was that the cartilage would get scarred and she'd end up with a cauliflower ear. And I hope you can appreciate that there's a large amount of swelling. In the operating theater, they peeled back the skin. She had a large amount of pus, and it grew a pure culture of Pseudomonas aeruginosa. So the Pseudomonas may have gotten in from maybe bath water or even from the skin when she had the piercing. So bottom line, she needed a surgical procedure to drain the pus so that she wouldn't end up with a scarring of the ear.
One thing, if you don't mind, I will add it up over here. If you show the picture, I just recently had this case actually in my clinic. The one thing which I really noticed in that is in perichondritis, the earlobe, there will be no redness over there, or it will be very minimal, which could be actually. So
yeah, agree.
There is a spinning of the earlobe.
Yes. And if you look, and basically what happened here is probably at the time of the procedure, there was inoculation of the organism and multiplication over a number of weeks with spreading of the organism between the cartilage and the skin. So the pain was excruciating. Okay. The custodian, he develops this blistering like eruption, the fingers swollen. I asked him, what were you doing? He says, I was cleaning the fur room. And he was cleaning the room where they keep the fur at Lower Fort Garry, the historical site. And he lowers his pants and he shows me this dreadful erythematous patch. So what are the things you'd worry about with someone who's been handling all these furs? And by the way, these animals have been dead for decades. I'm sure the fur that was there.
Anthrax, brucellosis, all sorts of weird stuff.
Exactly. And I can tell you, I was terrified with what was going on. So I treated him with intravenous gentamicin and vancomycin because I honestly didn't know what he had. He ended up having community-associated methicillin-resistant Staphylococcus aureus. So he had a community MRSA, and these organisms can be very virulent. They produce the Panton-Valentine leukocidin, which basically inactivates white blood cells, and the abscesses get really big. I didn't have a clue what this man had, and I'm glad that we gave him vancomycin and gentamicin, and that he got better. This was a completely crazy story. And we actually published the case in the Canadian Medical Association Journal. I'm going to spare you all of this. Okay. Young engineering student develops fevers, chills, goes to the emergency department. Between the time that he registered an emergency and the time that it was his turn, now many of you are going to laugh and say, yeah, that was 24 to 48 hours. It wasn't quite that long, but between the time that he registered, he kept having fevers and chills and feeling progressively worse. He gets into stretcher bay, he gets into a gown, and he was shocked by all of these spots. He has a sudden respiratory collapse. He's intubated. The question for you is, what are the clinical findings compatible with? And then once we've answered that question, I've got a bunch of other questions. So he's got these hemorrhagic lesions from head to toe.
The bacterial meningitis.
So Neisseria meningitidis, for sure.
Yeah.
So the next question is, what do we do with the pregnant emergency physician and the 2 medical students that were involved in the intubation? And by the way, no one was wearing a mask.
Rifampicin.
You've got to
It's
treat them.
prophylaxis.
Okay, I agree. So everyone gets prophylaxis. Let me ask you, does the janitor who stuck his nose in the cubicle during the intubation require prophylaxis? No. Within 1 meter, within 2 meters, yes. But not the janitor who's, snooping, not the registration clerk who's behind the bulletproof glass. So now we talk about prophylaxis. 2 medical students, both of them not pregnant, ciprofloxacin, rifampin, perfect. What do you do with the pregnant emergency physician?
Call you.
It is a pleasure to help. You would give her a dose of intramuscular ceftriaxone because you don't want to give ciprofloxacin and you don't want to give rifampin. And then that should be it for the exposure. What's the lesson learned? Wear appropriate respiratory protection when doing intubations. Okay. The hairdresser.
I have a question. How do you differentiate this rash from hemorrhagic fever? Is it similar or different?
Hemorrhagic fever, there'll likely be, so a couple of things. In this case, platelets are normal. Hemorrhagic fever, platelets usually low. Hemorrhagic fever, you also got evidence of hemolysis. So, and then I don't have any experience with hemorrhagic fever, although Health Sciences Center is the location that patients with hemorrhagic fever will go. So that's all I can say to you.
Okay.
So the hairdresser. This is a crazy story. The hairdresser is right-handed, so she cuts the hair with her right hand. The scissors are in the right hand. And she holds the hair that she's cutting with the left hand. She cut her hand with the tip of the scissors, which she does all the time, about 2 months prior, and the lesion hasn't healed. The only piece of information that she revealed during our interview is that a few days after she cut her hand, she cleaned her son's aquarium.
Salt water or fresh water?
It was fresh water. So now we've got the story of the aquarium. We've got this non-healing boo-boo on the finger. What do we do?
Swab it.
So we swab it. So the question is, for what are you going to swab it?
I would go bacterial CNS and fungi.
And what else?
Oh.
Okay, remember, and
Sure.
this is very important. You need to tell the lab what you want them to do because they have no there's no context. They just get a swab. So bacteria will give you staph, strep, E. coli, Klebsiella, etc. Fungi, they'll look for blasto, they'll look for candida. But what specific bacteria were you thinking of? Because I think you're heading in the right direction, but what specific germ?
Like her lesion is before cleaning the aquarium or after cleaning the aquarium?
She cut the hand before cleaning the aquarium, and she always does it with her bare hands and scrubs everything and washes everything.
I know of it, but I can't remember the name.
So
not erythiploid. It's
okay.
Yeah.
Erysipeloid is a streptococcus, and it gives you a bright red erysipelas-like condition. Okay, so you're almost there. You're almost there. So you sent it for routine bacteriology. You sent it for fungi. What's the one thing that you haven't sent it for?
Anaerobic bacteria.
Okay, anaerobic bacteria, you're not going to recover anything, but
Off the
okay.
skin.
Sean has almost got it.
A parasite, maybe?
Definitely not a parasite.
It's
Mycobacteria.
Mycobacterium.
yeah.
So we recovered from the hand Mycobacterium marinum. And the story fits perfectly. She has a breach or a break in the skin, and she then cleans the fish tank, and the organism got into the wound. She was treated with clarithromycin for several months, and it went away.
You should publish a book of all these cases. It's very like, you'll be very rich.
No. Okay. A cyclist impales himself on a branch while BMX biking or motocrossing or whatever. He has a small bowel laceration and a splenectomy. He's seen in follow-up, and he asks, when can I start cycling again? What else do you need to consider? He has a splenectomy now. Now what?
Needs to be vaccinated.
Exactly. So which vaccines in particular?
Pneumococcal.
And okay, so the broad collection would be the encapsulated microorganisms.
Okay.
So you've got pneumococcus, what else?
Meningococcus.
Meningococcus, what else?
Haemophilus?
Haemophilus influenza, exactly. So ideally, in the ideal world, this fellow would have gotten his vaccines before the splenectomy, but you can never plan when you're going to have a traumatic splenectomy. So then you would do it ideally, if this is a reliable person who will attend after, will attend, about 6 weeks afterwards would be reasonable. The reality is, since we can't predict who's going to be reliable and who's not, you give the vaccinations before they leave hospital. But certainly, Haemophilus influenza, Neisseria meningitis, and Streptococcus pneumoniae would be critical to give. Okay. This fellow has no medical history, none. He squeezed a pimple on the inside of his nose, and he develops this classic appearing raised eruption. It's almost like a plateau. You can run your finger over the normal healthy skin, and then here there's an elevation, and it's just in this distribution. No fevers, no chills. He feels actually quite well, but he's quite concerned about the hot lesion on his face. What is this?
Staph infection?
Strep infection.
Yeah.
This is erysipelas. This is group A streptococcus. Now, you thank you for your answer, because it allows us to jump into a whole different discussion. This infection gives you that classic appearance because the streptococci are causing the infection in the superficial soft tissues. So you've got all of the edema in the superficial soft tissue. And this redness is toxin mediated, and this plateau-like abnormality is from the edema. Staph infections occur lower in the soft tissues, and that's why they give you that sort of confluent appearance. So thank you for bringing that forward. So this fellow has erysipelas. Penicillin is the drug of choice, but penicillin is a nuisance to administer multiple times a day. So he was sent out on intravenous ceftriaxone and did fine. Okay. This fellow was working on a farm and was taking care of this lamb that needed to be bottle fed. And he developed this lesion on the thumb. And it's interesting because on further questioning, the fellow indicates that the lamb had a cold sore-like condition on its lip.
Don't they?
So this is, sorry?
I have a friend who raises lambs, and they can get a like a pox type thing.
So this is, in humans, it's known as ORF, and it's caused by a parapox virus. And this virus can cause cold sore-like conditions in lambs and baby goats. And it's in the livestock, it's known as scabby mouth. So this fellow, from bottle feeding the lamb, likely had abrasion of the skin by the tongue, or even nicks from the teeth, and the virus inoculated from the mouth of the lamb to the hand of the caregiver. So this is ORF. It will resolve with time, and on electron microscopy, you see these bullet-like viruses. So well done. Okay. Electron bursitis, what do we do? What's the pathogen? What's the plan? Number 1, 2, and 3 pathogen is Staph aureus. Methicillin susceptible or methicillin resistant. Basically, aspirate or incise and drain, but the pus needs to come out, otherwise it will basically start draining by itself. So incise and drained. So we sucked a lot of pus out, incised and drained. It healed uneventfully with some oral amoxiclav. Okay. This fellow presents with this massive swelling in the neck. And you can see this drop of pus. It was hard as a rock. Was just diagnosed with type 2 diabetes at the time that he presented to hospital. He uses a clipper to shave his head. And this thing is massive. The induration is from here to here, and painful as hell, here to here. What is this condition?
Like a carbuncle almost.
That's right. This is a carbuncle. And a carbuncle is basically a collection of furuncles. So it's almost like a rabbit warren where you have multiple channels. Although he had a little bead of pus, this was hard as a rock. So what we did, because we didn't know if it was MRSA or MSSA, we treated him with IV vancomycin. We got him to do warm compresses. And about a week into the treatment, he had an explosion. And I don't know how much pus drained out, but it was a lot of pus drained out. And over the ensuing few days, it just resolved uneventfully. So he received 2 weeks of vancomycin and basically an incision and drainage that occurred by itself. So it's a carbuncle. Always think about possibility of diabetes. There's a strong association with carbuncles and diabetes. And I don't know why, but it is. Okay. Sustained a trauma and bone is palpable. The X-ray basically shows this bone destruction. Now what?
So being osteomyelitis?
This is without a doubt osteomyelitis. So most likely pathogen Staph aureus. What do we do with this? Well, I'll tell you right now, we're not going to be fixing this with antibiotics alone. the bone and joint space are involved. This person basically needs an amputation of the digit. Don't waste your time with antibiotics. Call plastic surgery. I mean, of course, give antibiotics, but call plastic surgery for the definitive procedure. I was giving a talk in Los Angeles many years ago, and I saw this fellow that says, "Won't lie, need weed." I had to give him some money for his honesty. So this person presents with this episode of cellulitis of the dorsum of the foot, presumably arising from this lesion on the sole of the foot that's been there about a year. Non-diabetic, not painful. Now what?
Biopsy?
Absolutely. Squamous cell carcinoma. Dressing change reveals all of these maggots. Now what?
Lean.
Basically, wash with soap and water, put all the maggots in a garbage bag, throw the garbage bag away because those maggots will become flies. And thankfully, they don't transmit disease. If anything, they help to clean the wound. What happened is during a dressing change in the summer, flies must have landed on the wound and deposited eggs and led to this maggot infestation. It's ugly, but thankfully not harmful. Okay. Lady presents with this arm. It began as a cellulitis. She had excruciating pain, but then over a few days, the pain disappeared. And now she presents with this arm. What's going on?
Is that like necrotizing fasciitis?
So ultimately, to make the diagnosis of necrotizing fasciitis, you have to think of the diagnosis. So the key hint in the story was excruciating pain. You know, the way it's usually described as pain out of proportion to clinical findings. So she had some erythema. I don't know how this lady endured the excruciating pain. The pain is caused by ischemia of the nerves caused by thrombosis of the feeding vessels. So basically, she went to the operating theater. She had an incision to see if the fascia was intact. The fascia was not intact, and she ended up having an amputation of the arm. But I mean, this is an insane story. So the key hint for necrotizing fasciitis is pain out of proportion to clinical findings. And treatment is, before treatment, you have to establish the diagnosis. And to establish the diagnosis, you need to do a cut down to see if the fascia is intact. So if this presents to you, get them out of your community and straight to a center that has availability of plastic surgery. And start antibiotics. Basically, you can give Vanco, Piptasia if you want, meropenem if you want, or ceftriaxone, Vanco, ceftriaxone, Clinda, and get them out. Oh, sorry. Okay. Fellow from a nursing home presents with this necrotic, basically erosive lesion on the scrotum that extends onto the perineum and on, oopsie. And there's another slide where it extends onto the back.
It's the gangrene. I forgot the name of that. It's like a fortune.
Corneas. Corneas
Corneas
gangrene.
gangrene. You're right. Corneas gangrene. Usually seen in elderly, diabetic, malnourished. And this fellow was elderly. He was diabetic, probably malnourished. Anyway, treatment is an aggressive debridement. The debridement, basically, he was treated with comfort measure and he eventually died a few days after the photograph was taken. But he would have required a perineal debridement it would have been a massive surgery. Okay. This fellow had countless skin and soft tissue infections of the right lower extremity. Why is he having, so over the course of a year, he probably had a dozen skin and soft tissue infections. Why did he have so many skin and soft tissue infections?
Lymphedema?
Sorry?
Does he have lymphedema?
Sure. Not really. When you look, the leg is pretty well, it's not massively swollen. He does have a bit of swelling. Lymphedema is a good thought because that basically alters, there's altered lymphatic flow and organisms are slow to clear. So lymphedema is a good thought, but the leg looks pretty normal. You're going to go ahead.
Is he diabetic?
No, he's not diabetic.
Is there anything going on in the feet, like tinea or anything like that?
So when you look, you spread the toes apart, he's got tinea pedis. So the breaks in the skin caused by the yeast basically serve as a portal of entry for microorganisms. So we treated this man's athlete's foot, and he did not have any further episodes. So if you're getting people coming to your practice with recurring infections, or they present for the first time with a big cellulitis, look between the toes, because maybe they've got tinea pedis, and it's the tinea breaking the skin, allowing group A streptococcus and Staph aureus to enter, causing an aggressive skin and soft tissue infection. You don't need anything more than clotrimazole cream. Just run-of-the-mill clotrimazole. You don't need Canesten brand. You don't need Lamisil. Run-of-the-mill generic clotrimazole cream is all you need. You always check between all the other toes to make sure. I usually advise people that if they've got it in one place and you're treating one, treat all the other ones too, just to be absolutely certain. General approach is wash the feet with soap and water, pad them dry, and then apply clotrimazole cream. Massage well into all of the web spaces, and within probably 7 to 10 days, that should be resolved. Okay. This fellow presents with these slightly raised lesions on his penis. And those are not my hands.
Where are the gloves?
Yeah, no, those are his hands, thank God, not whew. So basically, this looks like secondary syphilis, and serology confirmed it. So remember, syphilis is the great mimic. It can look like anything. This fellow separated his cat and another cat that were fighting. He got bitten here and here by his cat. He developed some redness and swelling. He received some oral amoxiclav, but despite that, the knuckle became very swollen and exquisitely painful. He was unable to move the finger. Now what? What's the diagnosis? What do we do? What investigation do you do?
I think it's
X-ray?
lymphadenitis.
Okay. Okay. So he could have a tenosynovitis, you're right. X-ray for sure. See if he's got a piece of retained cat tooth or whether he's got septic arthritis. Okay.
Cat scratch fever?
Okay, remember, cat scratch fever is caused by Bartonella henselae. So not cat scratch fever. He might have Pasteurella multicida causing infection in the joint. Bottom line is he had a septic arthritis because he had excruciating pain from axial loading. He went to the operating theater. They were able to drain a pile of pus out of his hand. And to make a long story short, he did fine with the irrigation debridement and intravenous ceftriaxone. So beware, cat bites can be very aggressive because the cats have sharp pointy teeth penetrating deep into the soft tissue. So here, the cat penetrated into the joint capsule. This fellow was a landlord, and he collected rent personally. He went to collect rent from one of his tenants, and she didn't have rent money, so she performed fellatio as an alternative to rent money. And I can tell you, I don't know about the things that you hear in your practice, but sometimes I think to myself, like, these stories are too bizarre. You can't make this up. So he presents with this lesion, exquisitely painful on the penis. And when he retracts the glands, and those are his fingers, not mine, he's got these well-circumscribed lesions.
Herpes.
Sorry? Exactly, herpes.
Yeah.
That's exactly what it is. So now he says it was fellatio. It may have been something else. To make a long story short, this is herpes until proven otherwise, and the swab confirmed herpes. So this fellow sustained injury to the foot in an industrial accident many years prior. Now he has diabetes, he lacks protective sensation, develops a neuropathic foot ulcer. The ulcer waxes and wanes, he gets some antibiotics, it gets better. The antibiotics stop, it gets worse. He presents, we put a swab to take a specimen, it goes right through the foot. We grow Staph aureus, we feel bone along the way, so he's got osteomyelitis. We treat him for a prolonged period of time, and it healed because we never had effectively treated his osteomyelitis. All of the previous short courses of antibiotic did not allow for a complete and thorough treatment of the osteomyelitis. We treat most of our diabetic foot osteomyelitis with oral antibiotics. We treat aggressive and large cases of osteomyelitis with IV. So don't think you're mistreating your patient by giving oral antibiotic therapy for osteomyelitis of the diabetic foot. A 41-year-old man who immigrated from the Philippines 8 years prior, works as a welder. For 1 month, he had night sweats and intermittent fever and weakness. He continues to work as a welder, but is finding his job harder to do due to fatigue. He's had no recent dental work, and in fact, his teeth are in excellent condition. He presents to the Seven Oaks Hospital, from which I receive a telephone call Saturday night at 8 p.m. Difficult to know what's going on with the story, but I suggest to them, intermittent night sweats, intermittent fever and weakness. Who knows what's going on? What are you thinking about what could be going on?
Malaria, TB.
Tuberculosis.
Okay, so great thoughts. Malaria, he's from the Philippines. He's been in Canada 8 years, hasn't gone back. I mean, it could be malaria, highly unlikely. TB, absolutely could be TB. Chest x-ray is clear. I honestly don't know what's going on. I suggest get some blood cultures, start empiric ceftriaxone. I'll see him Tuesday morning. We see him Tuesday mornings. The fevers and chills have recovered. Have resolved. He's feeling much better. An organism is identified in the blood, and it's Streptococcus suis. He's got a heart murmur of aortic insufficiency. What's going on?
Is it endocarditis?
I think it's endocarditis. So we get an echo, and yeah, he's blown his valve. So we treat him with ceftriaxone, and ultimately, about 8 weeks later, he ends up having an aortic valve replacement. So he must have had a bicuspid aortic valve. More history from the man. Every few months, he and his wife buy a side of pork at Costco or from a local farmer or local butcher, and he basically prepares it in smaller portions, and he shares it amongst friends and family. Streptococcus suis comes from pigs. So it's certainly well within the realm of possibility that he developed endocarditis from a laceration on the hand, and I left that out, sorry. He had a laceration on his hand. So it's certainly possible that he had a transient bacteremia, seeding of the heart valve, and an endocarditis. So crazy story.
I had exactly same patient, and he was from Philippines, and he was actually pork butcher.
There you go. These stories are insane. So about 1 month prior to the current presentation, he sustained a deep laceration to the left hand when he was using using to prepare pork. Anyway, so I hope that the session was of value. It provided you with 2 hours of entertainment, and hopefully these crazy stories will stick in your mind for when you end up seeing these crazy stories. So only trust accredited local and national laboratories, and don't get into an argument with anyone who thinks they have Lyme disease, because you will lose. Just because something's hot and red doesn't mean it's infectious. And when in doubt, call a friend. I spend my life on the phone calling people for help. So feel free to call. You know where to find me. I hope that was of value, and good luck with what you're doing, and call anytime.
Thank you so much.
My pleasure. Good night, guys.
I have one
Thank you,
quick
Dr.
question.
Embil.
Yes, sir.
So we had this patient who presented with a chronic low back pain, and eventually an MRI was requested, and it was done almost about 10 months later.
Oh,
And the report comes in that he has discitis and abscess, and he has no fever. He's not septic. I mean, is that a likely thing that you have discitis and abscess on the spine with no fever and with no signs of infection other than the back pain?
it is certainly within the realm of possibility. So this is year 34 for me in practice. In the old days, we used to make the diagnosis of spondylodiscitis on CT scan, and I'm sure that we missed dozens and dozens of cases. Now with MRI, we find discitis everywhere. I'm sure at some point your patient likely had a transient bacteremia, probably had associated fevers and chills, and ultimately, this process has been ongoing for a long time. And, we see people all the time that, they have a gradual back pain, and then they present in the emergency, they have an MRI, and it shows spondylodiscitis. And the reason we're seeing more of it now is because we're having, people who are having lots of invasive procedures, where people are getting biologic agents, lots of hemodialysis patients, and every time you access either the dialysis catheter or the fistula, there's potential for bacteremia. I can tell you at the Health Science Center, we have an explosion of crystal meth use, and MRSA and MSSA bacteremias from injection drugs. So I think you have to interpret with caution what the patient is telling you, but if there's back pain, always keep in the back of your mind that there could be a spondylodiscitis.
Okay. I was just surprised that he didn't have any fever. His white cell count was normal. Yeah, so it
No,
didn't.
we see this. The other thing is, could it have been tuberculosis? Sort of the cold abscess. So to answer your question, it seems unusual to go 10 months, but maybe he had low back pain, as a mechanical low back pain, and ultimately had seeding of the site from a transient bacteremia. So yeah, I mean, we see it, and we see all sorts of manifestations. So don't dismiss the back pain, particularly if there's any history of injection drug use or implanted devices or intravenous cannulas.
Thank you so much.
Again, Dr. Embil, I will just add one point over here. It's very hard to actually, on the basis of just having a suspicion, to get an MRI early as possible, because
no, I agree.
There's a specific criteria. They said, like, you have the constitutional symptoms, or you have those cardiac venous symptoms and all of that stuff, which probably would be negative in this case.
No, absolutely. See, and that's what makes clinical medicine so difficult. When you start putting rules, unfortunately, humans don't follow rules. No, I agree with you. I agree 100%. What I'm going to say to you, when in doubt, pick up the phone and call. I don't know who you would call. I'm always happy to take phone calls. In fact, I love the phone calls. Many of these cases arose from crazy phone calls where my answer to the question was, send them, we'll figure it out when they get to the city. But I agree with I agree with both of your comments. A, seems like a long duration, and B, it is challenging to get MRIs. So I don't have an answer. I don't have a solution. I agree with you with the problem.
Thank you for the presentation.
My pleasure. Good night.
Good night, Dr. Embil. I always love
pleasure.
your presentations.
My pleasure. Bye.
Bye.
Night, Dr. Embil. Thank you.
My pleasure. Bye, guys.
Oh, by the way, I want to talk to you offline sometime if I can. I'll probably text you on Tiger or something like that.
Go for it.
Okay, fair enough. Thank you.
Bye.
Bye.